So I think we're going to start. A warm welcome to everybody who's watching this TricValve Masterclass. My name is Jörg Hausleiter. I'm here an interventional cardiologist in Munich in Germany. And it's my great pleasure to welcome you all to this next session of the TricValve Masterclass. In the next hour, we will see probably a very exciting case, how the TricValve is being treated, or how a patient is being treated with the TricValve. The entire case will be performed in Spain, in Madrid, and I welcome the entire team in Spain. We are very glad that we have one of the most experienced teams who are performing TricValve implantations today with us. And with this, I will pass the words now to Dr. Recalde, who can introduce his team and also the patient. But before that, I will also ask you to communicate with us, to ask questions using the question and answer function or the chat function. We will try to answer all your questions within this next hour so that you get all your open questions answered. With that, Dr. Recalde, do you want to start?
Okay, good evening, good afternoon, everyone. Welcome to this webinar. Thank you, George, for being here with us and to be a moderator and help us with the case. And I would like to thank Products and Features for sponsoring this webinar. And I will present my team. My colleague, Dr. Elisa Salido, is going to present the case. He's the second operator in this case. And the outstanding imaging team with Dr. Covadonga Fernández Golfin is the head of the unit. And also our nurses team with Mercedes, Enrique, Ana, and the anesthesiology, and Angelica, the anesthesiologist, is very important in this case. And Dr. Luisa Salido is going to present the case, the clinical case. Luisa, as you want.
Good morning, everybody. This is a 69-year-old female. She has a rheumatic heart disease, and surgery was performed in 2011. Two mechanical prostheses in mitral and aortic position were implanted, and the Vega tricuspid annuloplasty was performed. She also had atrial fibrillation, and a pacemaker were implanted in 2019. The patient developed right heart failure symptoms, and the echocardiogram show a normal functioning mitral and aortic prosthesis with normal gradients in both prostheses. And a torrential TR, mainly due to severe annulus dilatation, were shown with a gap of 20 millimeters. And besides, also the patient had a pacemaker lead that could be playing an important role in a TR. In that moment, we decided to implant a cardioband. These are the images from the procedure where we implanted 17 anchors successfully, and the TR improved from torrential to severe, and the gap improved from 20 to 15. During the follow-up, the symptoms worsened, and a new echocardiogram was performed. We realized that the TR from severe to massive, and as you can see in this graphic, the BNP levels at the beginning improved, but and were stable in all the follow-up, but the patient had a worse 6-minute walk test. So for this patient, we have a patient with a massive TR and symptoms, and the option could be surgery and percutaneous. Surgery was discharged because the high risk of the patient, and we have several option, percutaneous option. One is clip, but because due to the shadow from cardiovan and the prosthesis could be a very challenging case. So we decided TricValve for this patient. So now Dr. Angel Recalde is gonna explain the CT plan that we perform.
Okay, thank you, Luisa. For planning the procedure is essential and is based on the CT measurements. But before starting with the CT scan, George, what's your opinion about this patient? What to do with this patient? This patient is not a high risk patient, but he had a previous surgery. He rejected a new surgery because he had neurological problems with the first surgery, and it's a patient with a very dilated annulus with a very huge gap, and also with a pacemaker. Our first option was to treat with a cardiovan, but for cardiovan it's not a good case, and the TR at the beginning was torrential. In the end, nowadays, is massive. What do you think about this case? Would you do another different thing, or what's your opinion?
Well, as you pointed out, it is a very complicated patient. I think we can be happy if that all those rheumatic diseases are being seen less and less because they're so difficult to treat. And as you just pointed out, the patients with such a rheumatic tricuspid regurgitation usually has also some thickened leaflets, and it is very complicated to treat those patients by any interventional therapy. A clip procedure, as you just mentioned and your team mentioned, is almost impossible. The gap size is one aspect, but usually also the leaflets are very tethered and fibrotic. Yes. So far, we didn't have very good options to treat such patients. I just treated one patient, very similar patient, with an autotopic valve replacement as a compassionate use. But otherwise, I think the only option what we do have right now, and the only CE marked option, is what you're going to show us today with the TricValve, because otherwise this patient will have no other option than medical therapy.
Okay, Josh, thank you. I completely agree with you. So, Antonio, could you show us, okay, the CT scan? So we chose the valve according to the measurements of the CT scan. As you know, the right brachycephalic vein is 21, the confluence is 25. Above the pulmonary artery is 29, and in the middle of pulmonary artery is 31. Below the pulmonary artery is 32, and the right transition is 37, and the total length is 65 millimeters. The next one, please. So this drawing I did yesterday, and is the measurements of the superior vena cava, and this is the valve, and this is the number 29. As you know, TricValve is a self-expanding nitinol structure. The shape of the superior vena cava is this. It has the upper part of the valve is anchored in the confluence or in the right brachycephalic vein. It has a low radial force only for stabilize and to get a better alignment with the superior vena cava. Then the value of the valve has a high radial force to anchor and to fixate the valve against the superior vena cava walls. Is the most important part of the valve. In the inferior part is the valve. In this case, has also a high radial force because the valve is in the lower part and to avoid the deterioration of the leaflets. So with these measurements, the appropriate valve is 29, and in the belly this is 32% of oversizing. And next one, and for inferior vena cava, also the right atrium and inferior vena cava transition is 42. The top of hepatic vein 36, below is 38, and 5 centimeters below is 34. The length from the top of the hepatic veins to the right atrium is nearly 10 millimeters. And the length from the right atrium below the hepatic veins is 32. So 35, sorry. And the next one, so this is the drawing, and the appropriate valve in this case is 41. 41 in this case, the shape of this valve in the upper part it has a high radial force to fixate the valve and to prevent the black flow from the inferior vena cava to the right atrium. And it has a short skirt to prevent the occlusion of the hepatic veins. In this case, with this size 41, the skirt is 28 millimeters. So we have 10 millimeters from the top of the suprahepatic veins is the landing zone to the right atrium, and we have 28 millimeters of the skirt. So in this case, as always, the most important is to implant the valve as low as possible, and but avoiding to occlude the hepatic veins. So this is the CT scan. This is the valve that we are to use in this case. And for now, we have the pressure in the inferior, superior, and right atrium. In this case, the pressure is a big wave of 28 millimeters of mercury. And we did the first angio. The first angio is this in the superior vena cava. And the patient has a pacemaker, so it's very easy to identify the denominate vein. So the pigtail is in the right jugular vein. This is the injection. So the target zone is to place the valve with the belly above the pulmonary artery. We see the catheter in the right pulmonary artery, and we have another pigtail in the denominate vein. So we have to the target zone is to implant the belly above the pulmonary artery, but without occluding the innominate vein. So in this case, we have two left axes for a pigtail in the innominate vein, and the other one for a marker in the right atrium, in the right pulmonary artery, and in the right femoral vein we have a sheath is 224, and we have I inserted a Langurquist, a high support wire in the right jugular vein, as you see in this case. So we are prepared to insert the first valve. Juan, if you wanted to explain the valve and the mechanism of the valve.
Yes, sir. Thank
May
you
I
so much.
May I ask one or two questions before?
Yes, Josh.
So first, can you show or did you record the pressure tracings, because the audience was not able to see the pressures? And I think
Antonio, okay.
It would be nice if it would be possible.
Yes, yes.
Here, okay.
This is the pressure of the pigtail in the innominate vein. It's the same. This is the pressure in the suprahepatic, in the superior vena cava and right atrium and inferior vena cava.
So we have
It's
a significant V wave, which we always think is very important, that because it will allow us the valve, which is not in the autotopic location, but also in the heterotopic location, is nicely opening, but more importantly is nicely closing, because otherwise we will not see the effect of the TricValve, correct?
Yes, correct. Totally agree.
And for the procedure, did you do a pre-close of the right-sided access?
Yes,
Broke light or something?
only with one pro glide, and then in the end, 8 switcher, in the end of the procedure. But now we only have one pro glide.
Wonderful.
In some cases, it's enough to close the vein. So in cases, we can finish with a suture.
Okay, thank you so much.
Okay, now I'm going to explain you. Thank you, Angel, for the introduction, and later for the next questions. Now I'm going to introduce you how is the system preparation, the TricValve. Here is Vanessa, who has prepared already a system. And the system as, let's focus, yes, please, the system here. Okay, so you can see the system on the table. This is the system for the superior vena cava vein. And what a very unique feature that the TricValve has is that is the only device that the valve comes already preloaded into the delivery system. So as you can see there inside the catheter, you can see already the valve, which comes directly from manufacture like this. So it means less contamination and less human manipulation during the preparation. So the preparation takes around 3 minutes. It's very easy. It's just flushing with a saline. Could be with heparin or not heparin, doesn't matter. And you can see that the syringe now is connected to the upper port, and this is for flushing the valve. That takes around 3-4 minutes for flushing to make the pericardium wet, and therefore the leaflets will coapt properly. So this is because the pericardium becomes dry. It's dry pericardium, and the tissue is prepared to resist, pre-mounted into the delivery system. So once the device is flushed with the upper port, then you can see there is a wheel, it's a turn that is for closing the system and opening. Opening is clockwise and closing is counterclockwise. And there is one other port at the distal part of the catheter, and this is for flushing the inner wire, the lumen wire. So just one flush is enough, and then the system is totally ready to be used in the intervention. So now we will move to the system to Angel, please.
Okay, thank you, Juan. Juan is one of the, I think is the best expert in the world with TricValve. He's the specialist, and he's a very clever guy, and also is the best expert in TricValve.
After you.
So please, the valve.
Yeah, can you take the valve, Vanessa, please?
Okay, please. So we use a Landerquist wire. George, which wire do you use in these cases?
I started with the regular Amblat super stiff wire, but more and more I'm using also the Landerquist, which gives us a much better support for this type of procedure. Absolutely, I'm doing just the same.
Okay, I predilate with a 24 French dilator, and now.
Do you want to tell the audience the size, the French size of your delivery system?
The delivery system is 27 French. So as you see, I am advancing the valve. This is the nose cone, and you can see the upper part, the belly, and the lower part of the valve. So the position is very important to place the wire as high as possible, because the nose cone is a traumatic nose cone. It's flexible, but it's very long, and you need a space. So it's important to place the wire as high as possible to accommodate the nose cone. So we have to implant the valve, the belly of the valve above the pulmonary artery, try and avoiding to occlude the innominate vein. So for me, maybe this is a good position to start. What's your opinion, George?
It looks good, perhaps a little bit too high for me, but you can still also see when you give some contrast, as you just do, how the valve is located, and it's still always easier to pull down, but you cannot, of course, get higher with the valve.
Okay, I think it's good to see in this case the ribs of the patient, because if you can see the lower part of the rib, I think this is a good mark to start, and I think it's a good position. The belly is above the pulmonary artery. Juan, what's your opinion?
I'm agree. I think it's a good position. Nevertheless, if we let the valve just to go 2 millimeters higher, because
Yes,
the lower part, the bottom, is really close to the pacemaker lead, as you can see in the right atrium. So yeah, I think this is the area in the middle of the rib.
In the middle, yes, I agree with Juan. Yeah. Okay, Josh, if you agree, we start with
absolutely. No, please go ahead.
Okay, then Luisa will start to rotate clockwise the knob. Huh. Yes, the way of doing is to rotate clockwise the knob of the valve is very easy. At the beginning, we can do quickly. As I said, it's an ethanol structure, so it takes time to get its original configuration with the blood, with the temperature of the blood. So we have to do it slowly, but at the beginning we can do it quickly. And a good aspect of this valve is always this is a self-expanding valve, and always the catheter the tendency is going up. So I have to keep tension, because the system always the tendency is to go up. So as you see now, is flaring the valve, the upper part of the valve. I think is the place that we try to implant.
Mm-hmm. Looks very good.
Our reference is the upper part of the rib. And now, in a few seconds, the belly will be opened.
Do you want to share how much of the belly is covered and how much is uncovered of the belly?
Yeah, it's a good question, George. The skirt of the superior vena cava prosthesis is in the middle of the belly, from the middle of the belly to the lower part. So it's a long skirt, and it starts in the middle of the belly.
Good. Very good.
Now you pulled a little bit down, correct?
Yes, I am pulling down, because always the tendency is to go up. So I keep tension.
I think once the belly is released, that's the moment to release a little bit the tension, because the belly is going to be attached into the inner vessel wall. So the stabilization is going to be great at that point.
Okay, now the belly is deployed. So continue, Lisa.
Now you have a lot of experience with this kind of system, and you show this very nicely that this patient has also pacemaker leads. Have you had any troubles or experience with pacemaker leads also in the long term of follow-up of those patients?
No, the follow-up with our patients is good. The patients haven't had any problems with the leads. I will do an angio, because I have a pigtail in the innominative vein, and if the position is correct, I can retrieve the pigtail.
I think it looks like a perfect location, because the upper half of the belly is completely free. where the unanomated vein is connecting, but the lower part is covered.
Okay, so we are about to release the valve. So in this step, we have to do it very slowly. So the valve has 3 connectors. We are about to release the first one.
We do have one question from the audience. Can you hear me?
Yes.
Okay. The question is from France, from Dr. Van Bell, and his question is: the system inserted with a sheath or sheathless?
Sir, what is the size of the catheter, you mean?
No. If the device is being inserted with a separate sheath in the femoral vein, or is it sheathless? And I think you do it also without the sheath, correct?
Correct. It's sheathless. It's sheathless. It's important to pre-dilate up to 22 or 24 French, and then after remove the dilator and introduce the catheter sheathless. Correct.
So this is the final position. I think it's in a good position. So we try to pull down the valve very slowly to keep the wire in the right jugular vein. So Koba, can you show us can you see the valve by echo and the leaflets?
Explain, and if you take a look at the right image, you can see the leaflets there. I think we need a little bit more time to. Can you see it in the right image?
We have still the wire in the middle of the leaflet, so that's probably impairing the leaflet's coaptation at all. So once we remove all the material, probably will go up at all.
We do have another question, and this is just about your echo imaging. What is the role of the echocardiographic imaging so far? As I've also seen this, most of the procedure was performed with fluoroscopic guidance, but do we need to have a TE probe in the patient?
Yes, most of the procedure is performed under fluoro, but after the valve has been deployed, it is important to check the position of the valve regarding the how much valve we have, mostly more for the inferior vena cava, but also for the superior, how much valve we have inside the right atrium, and also to confirm whenever possible the normal functioning of the valve. Sometimes I should agree that it's a tricky procedure for us because superior vena cava and inferior vena cava, sometimes we're not able to see them that well, but I think, yes, we perform all the procedures with TE, and we try to check these 2 aspects of the procedure.
It's a good question, Josh. I think the superior vena cava, you don't need the echo. You can do it with fluoroscopic guidance, but for inferior vena cava, I think it's important to check how many millimeters are inside the right atrium. And sometimes with angio, you can see easily the right atrium transition, but sometimes in other patients with a very dilated veins, it's very difficult to see where is the landing zone of the valve. And for these cases, I think it's important to use the transesophageal echo. You can use the transthoracic echo, but sometimes in some patients, I think it's difficult. In the end of the day, I think the first cases and in complex inferior vena cava anatomies, I think it's important to use the transesophageal echo, and also the availability of the echo in your hospital. We are lucky because the availability in our hospital is totally, and we can have the echo without any problem. What's your opinion, George, about this question?
Well, we do it also as you just did for the superior vena cava. We're doing this without any echo guidance. For the inferior vena cava, what we usually do just a transthoracic echocardiography, because this will also lead us to the next question. Is general anesthesia necessary for this procedure, yes or no?
Yeah, it's true. It's true.
Because of course, if you have a TE probe in there, then I guess you need some echo, then you need full anesthesia. But if you do it with transthoracic imaging, you can also do it with without any full anesthesia, but just with the local anesthesia, correct?
Yeah. I agree with you. I think you can do it with transthoracic or with esophageal. I'm more comfortable to do it with esophageal, but it's true, you can do it with transthoracic. So we retrieve the superior vena cava valve, and now we are inserting the second valve, the inferior vena cava valve. I will do before an angio. The pigtail are at the level of the suprahepatic vein in the entrance. Okay, good. It's a very huge ostium of the suprahepatic vein, but very, very huge.
Yeah.
So I will repeat. We will repeat the angio in this, with the pigtail close to the inferior vena cava. Repeat.
No.
Okay, I think we can see the transition and the landing zone. But in this case, the ostium of the hepatic vein is huge. It's very difficult or impossible to occlude the suprahepatic vein. So we have a space to implant the valve in the correct position. What's your opinion?
Yeah, absolutely. I think it's a huge hepatic vein, and the skirt of the stent is something like 25 or 26 millimeter long. So you will not have any problem with the skirt and occluding the hepatic vein. So now you pull back the Lunderquist wire, correct?
Yes, I prefer to, because in some cases the superior inferior vena cava are not coaxial, and so if the angle between the inferior vena cava and the right atrium and the superior vena cava is an acute angle, is not coaxial, and I prefer to put the wire free in the right atrium.
Okay.
I think when you mentioned it's super important. We can see that in that picture when Angel did the contrast injection, it's super important to look the distance or the length of the suprahepatic ostium and to compare where is the end of the nitinol frame to find support below the suprahepatic ostium, because otherwise there is risk that the valve protrudes or prolapse into the suprahepatic vein. So it's important to compare where finished the ostium and how the length of the nitinol frame of the ABC device.
So
I think the position is good, Angel.
What do you think, this position?
What do you think, Dr. Hausleiter? I think it's good.
I think it's
probably
good.
Yeah,
I
think a good marker is the previous cardigan in the annulus.
Yeah, this is why you placed it, I guess.
Yeah,
just to have a good marker.
Yeah. Okay, let's start. But the deploy is the same. Is you have to rotate clockwise.
It's also important in this patient with pacemaker leads, where the leads is really close to the top of the valve, and to check in the echo that the leads are not interfering with the leaflet's motion before releasing. So we will see that when we open the valve. This
is a good point. One. because sometimes the lead is above the valve and can interfere with the leaflets of the valve.
So we have another few questions which we may want to answer. The length of the skirt for this inferior valve.
In this case, 41 valve is 28.
28 millimeter length.
Yeah.
Do you want to highlight on your fluoroscopy perhaps the different parts of the lower stand?
Yeah, as you can see that there is a white mark, and the length is I don't know if can you show the
yeah, I'm gonna show you that.
Now it's difficult because you need to.
Are we focusing on the screen or not? Well, you can see in the 19 frame, like more or less at the middle, there is like a not so radiopaque frame, right? So
yes.
So this is where the skirt of the TricValve ends, right? So it comes from the top to this middle part approx, and we can see it's less radiopaque. I think the valve went a little bit up, so probably we'll have to pull down a little bit.
I try to do it.
Nice.
Perhaps you want to show the echo on the left side.
Yes.
During this.
Yes, I think at this point it's good to see the echo. Oh, but how many millimeters are inside? Because in one in the one side near to the septum is maybe 10 or 15, and in the other
Looks
side
to me a little bit more like.
In the other side is very short. Well, it's nearly 0 millimeters.
15 millimeters in the part near the interatrial septum. Down is a little bit less.
What do you think, George?
No, I think it looks perfect to me, but I think it's just very nice to show to the audience how the upper stent frame is protruding into the right atrium.
In this case, the length from the top of the hepatic veins to the right atrium is 10 millimeters, and the skirt is 28. So we have 15 millimeters to put the valve into the right atrium. I think from 10 to 15 millimeters is a good position inside the right atrium.
I think it's a perfect position. I would continue.
Okay.
Totally agree. Actually, this is a very interesting case because we don't have too much distance from the septum. So it's important to keep also the distance for not pinching the septum in this case. And we cannot pull down too much because otherwise the valve could go down into the suprahepatic. So I think it's a very interesting case to control and to try to find a really accurate position.
So I had to keep tension because always the valve tends to go up. It's important to keep tension. In this case, my colleague Luisa is rotating the knob. If you do it by yourself, you can fix with the left hand the valve, and with the right hand we can rotate the knob. But it's good to do with two operators. So it's very important to do it very slowly because the nitinol needs time to get its original configuration. So the position cover is good. It's the same.
Yeah, I'm a little bit worried about the interatrial septum, as you were mentioning before.
Can we check with color to see if there is a PBL or not? I think we are covering perfectly.
Yeah, I think it's important. This question is to check if there is a leakage between the right atrium and the inferior vena cava. In this case,
I don't see any with color.
There is no leakage, so we can continue, Lisa.
There is a question about the paravalvular regurgitation. Do we see any paravalvular regurgitation in such procedures? And if so, would this be acceptable?
I think it's a good question. I think the best result is the hemodynamic result when you see the drop of the pressure in the inferior vena cava, and there is a gradient between the right atrium and the inferior vena cava pressure. So the normal result is a ventricularization of the right atrium pressure and a significant decrease in the pressure in the inferior vena cava. Very slowly, listen now. So if there is any leakage, if the leak is small, I think it's not important. The most important thing, I think, is the hemodynamic result. I don't know if you agree, George.
Yeah, I absolutely agree. Usually, even if there's a small paravalvular regurgitation, this has no clinical impact on the outcomes of those patients. I was wondering, by echo, you always see that the stent frame is touching the septum.
Mm-hmm.
Do you think that this will cause any problems over time, or do we need to pull down the valve like 3-4 millimeters down so that we're not touching with the crown of the stent the septum?
I think it's not important because the valve position is good. I am not concerned about this.
Now it's super important, as we mentioned before, during the release of the superior vena cava, the distal part has 3 connectors. So it's super important to release the connectors one by one, waiting at least 1 minute between each connector. And it's really, really nice to see now the drop in the pressures coming from the catheter in the suprahepatic. So this means that the TricValve is already relieving the venous pressure.
Can we see this as well? Because we do not have any pressure. Okay, thank you. When do you pull back your pigtail from the hepatic vein?
Yeah. Can you flush the pressure?
Another question from the audience is about the heart rhythm. If it makes a difference if the patient is in sinus rhythm or has a paced rhythm or atrial fibrillation, does it make a difference?
Okay, just sorry a moment, because we are releasing the first anchor, so the prosthesis is stable. It didn't move anything. This is in the right position.
No tension.
So now, yes, I release the tension of the valve.
Okay, nice.
Because we are about to release the third one. Because
I think we can respond to the question from Hoslater and let the valve.
Okay.
It's okay. It's okay. It went a little bit up, but yeah. It's okay.
Okay, Josh, what was your question? The question,
the question from the audience was about the heart rhythm. If the presence of sinus rhythm or paced rhythm makes a difference for the procedure and the outcomes.
I think most of the patients, I think more than 95% of the patients are in atrial fibrillation. Patients with severe or massive or torrential PR are almost all in atrial fibrillation. So the normal rhythm is, in this case, the rhythm is pacemaker rhythm, but almost all patients are in atrial fibrillation. So as you see, the pressure in the inferior vena cava now, the big wave at the beginning was 28, and now it's 15 millimeters. So
we don't see. Here. Okay. Yes. Thank you. Yeah. Now we see it.
No, déjalo ahí, Luisa, la válvula. Okay, I will try to. No, I will try to repeat the measurements in the right atrium and in the inferior vena cava.
We have one more question, and perhaps we can see this by echo. How much is the inferior stent now protruding into the right atrium? Because it jumped a little bit up, correct? And the question is, how much of the skirt is now in the right atrium, and how much is it below the diaphragm?
So how many millimeters are inside protruding the right atrium, Cova?
Voy. Esto, ¿no? So 2 centimeters.
In this case, it's 19 millimeters, and so we have a skirt of 28, so 9 millimeters of a skirt between the inferior vena cava wall and the prosthesis.
And you can nicely appreciate here the functioning of the valve. It's, I think, beautiful image.
Yes, I don't know if you can see the pressure in the right atrium.
Now we can see it again. Yes.
Yeah, this is the normal response or the normal situation is to get an increase in the pressure in the right atrium. So there is a ventricularization of the pressure. So in this case, the big wave in the right atrium is 40 millimeters of mercury, and I will do an angio and then pull down the catheter to see the gradient between the right atrium and the inferior vena cava. So I will do a new injection, a new angio to see if there is any leak.
No.
It's perfect. So no leakage between the right atrium and the superior vena cava or inferior vena cava. And flush the catheter, please. And I will check the gradient between the right atrium. As you know, 40 dB wave is of 40 millimeters of mercury. And this is the pressure in the inferior vena cava. The dB wave is 17 millimeters of mercury.
They're completely gone, almost no V wave, a good pressure separation.
Yeah, it's a good separation between the right atrium and the lower part of the body. So the patient is symptomatic, is in functional class 3 with edema and abdominal congestion. So we try to decrease the pressure in the inferior vena cava, and I think we got this objective.
Wonderful case. You get also some congratulations from the audience on the screens. Let's perhaps discuss a little bit about the indication. What do you think? What kind of patients are best suitable for the TricValve?
The selection of the patients is based on the clinical, anatomical, and hemodynamic features. So the clinical is patients with symptoms and signs of right heart failure, despite of optimal medical treatment, and the anatomical features for TricValve, I think patients with a very dilated annulus with a huge gap, and also patients with pacemaker, I think is a good indication, because in this kind of patients, the repair techniques such as Cardiovan or TriClip, the result is difficult, and the role of these techniques is poor, because the result is not good, and it's very difficult to achieve a good result with the repair techniques in these patients. And also it's important from the point of view of the hemodynamics to get a significant big wave. Such as in this case, we demonstrate at the beginning the big wave was 18 millimeters of mercury. So this is the three aspects: the clinical, the anatomical, and the hemodynamic features.
Wonderful. I would
for me this kind of, yeah.
Sorry, I would fully agree with your comments. There are two more questions regarding the medical therapy in combination with the TricValve. First, the medical therapy for right heart failure. What do you prescribe for those patients? And then the second question is about the need for anticoagulation. What are you prescribing in terms of anticoagulation and antiplatelets?
As you said before, almost all patients are in atrial fibrillation, so they are under anticoagulation, under anticoagulant therapy. So we have to keep this anticoagulant treatment. If the patient is not anticoagulated, I think it's enough with 3 months of vitamin K antagonist. And the question about the treatment, I think it's important to maintain the diuretic treatment, the regimen of diuretic treatment at the beginning, because in some cases the effects of the positive remodeling of the chambers need time to get maybe some days or weeks. So I think it's important to maintain the same regimen of diuretics, and to see the patient closely in 1 week or 2 weeks to see the response, because the normal response is to decrease the peripheral edema, and in some cases we can change the dosage of the anticoagulant treatment, because the patient can improve the liver and renal function. And also you have to check because most of the patients need less doses of diuretics. And it's important to rule out patients with precapillary pulmonary hypertension. This is and patients with severe right ventricular dysfunction. This is 2 contraindications for this therapy.
Wonderful. Thank you very much. The other question is perhaps about the right ventricular remodeling, because we do know that after a TricValve or Pascal procedure, we do see some remodeling of the right ventricle. Is this something you also observe in your TricValve cases?
Yes, in the series of TricValve study to get the CE mark with 35 patients with the CT scan, a 6-month follow-up, we can observe a positive remodeling with a decrease in the size of the right ventricle. And our concern is about the size of the right atrium, because there is a ventricularization of the right atrium with this technique, but the size of the right atrium didn't change significantly, and there is a positive remodeling of the right ventricle, because we are increasing the caret output. So this is a good response.
Okay, wonderful. So is there anything else you want to show, like the closure of the groin?
Okay, we will try to,
because we have like 5 more minutes.
Yes, we try to close the vein. Con una guía. So this is only a prolite. Do you use 2 proglides, George?
No, I also use, as you do, 1 proglide, and this is usually enough, and you only need like 1 skin suture, and this is like you get a good hemostasis with that. Usually it's not really a problem. Closing the vein is not really problematic.
Dai luz, por favor.
Dar luz.
Okay.
Luz.
Ok, Luis.
Espera, no, que no tengo, no he podido. Wait a moment.
And George, do you have experience to use an angioseal or another closed devices in the femoral vein?
No,
Only
I
ProGlide.
only do ProGlide as you do, nothing else.
Okay. We try to insert a new wire into the valve, but sometimes it's difficult.
Yeah.
Yes,
Okay.
now we did it.
I'm just summarizing two other questions. There was a question about anticoagulation. Yes, the anticoagulation is going to be lifelong due to the atrial fibrillation. And do we need some antiplatelets, and for how long? Well, it's mostly just the anticoagulation which is needed for the entire life, but more for the atrial fibrillation. Perhaps a question for you is: do you see a difference between vitamin K antagonists and DOAC therapy in such TricValve patients?
The recommendation from the manufacturer, the company is a vitamin K antagonist, but my experience, I really don't mind DOAC or vitamin K antagonist. For me, it's the same. I don't see any differences. And yes, I think it's a switcher. So the result is good, and now we are do a switcher. And the question about the antiplatelet regimen, these patients don't need antiplatelet treatment. Only with anticoagulation is enough. Yeah. And in the series with Tricus, the Tricus 0, there were only 2 thrombosis in the stent of the inferior vena cava, but without any clinical consequences. They can't. The thrombosis was solved with anticoagulation.
Did you check the ACT during the procedure, and what kind of ACT is your target? Is another question.
Sorry, the
ACT, the activated coagulation time.
Yeah, this is more than 250 as the usual procedures.
Okay.
Angel, I have and Dr. Jose, I have a question for you. For patients that, let's say, are frailty and risky patients with a chronic kidney disease and, let's say, poor RV function, which considerations would you take for precondition these patients in terms of medication and the contrast used during the intervention? What do you think is important to consider in this frailty population?
Well, of course, you need to do a CT study for your procedural planning, which is always of importance when you consider patients with decreased kidney function. So this is something you need to be aware of, that perhaps with the CT study and the contrast you're applying there, you have a small risk for kidney failure. Otherwise, what we usually see after those tricuspid interventions is that the kidney function is usually improving because the congestion, the venous congestion also on the kidneys is decreasing, and the kidneys are working much better, have a better inter-kidney gradient, so that their filtration capacity is improving. In terms of the prehab for such procedures, we do need the prehabilitation process more for leaflet-based devices, where we need to reduce the gap. For the TricValve procedure, I think there's less need for prehabilitation. Of course, you don't want to do the procedure in a fully decompensated patient, but otherwise, there's no need for long prehab as perhaps for other procedures. Is this what you were targeting?
Yes. Thank you so much.
Okay, I think the closure was easy with a switcher and only one prolite. So this is the final result. This is good. And my concern with this treatment, George, is when the patient has RV dysfunction, and also in the first 24 hours, the patients started with hypotension and oliguria and renal failure. And so in these patients, maybe you need to start with inotropic treatment. And this is my concern when I treat these patients. What do you think about this?
Well, I think we're still probably learning what kind of patients are the ideal candidates for a tricuspid valve replacement, being it either orthotopic or heterotopic, sorry. The RV function is something very difficult to assess. We do know that TAPSI is not really working very well. What we are looking at in the research assessment is if we can use more three-dimensional assessments of the RV function, which might be more appropriate for those kind of patients. But as you said, it's something we need to be careful. We should not treat patients probably at the current stage who have a very poor right atrial function, because those patients might be having a hard time after the procedure, although it's not very common that you do see acute right heart failure after such procedures, correct?
Yes, I totally agree, George. So, so to conclude, I think this procedure is very simple. It's a straightforward procedure, and I think it's the imaging requirement is not important if you compare with other repair techniques such as annuloplasty technique or edge-to-edge technique. So I think it's very simple. It's a quick procedure, and sometimes for specific patients is the only one solution that we have nowadays with CE mark, as you said before.
Yes, I would also congratulate you and to your team. It was a fantastic procedure. You get a lot of congratulations from the online audience. We had more than 100 participants still watching what you did. The results were perfect. And I think we all have learned quite a bit from today's masterclass. And with that, I would thank also the organizers, the sponsor, for this possibility to have this online educational session today. Thank you so much, and see you soon again.
Okay, thank you so much. Thank you.
Thank you so much. Thank you.